donor selection and phlebotomy. And this is, again, chapter 13 of your blood bank textbook. Here are your objectives. Please be sure to go over your objectives when you are studying for your exam. Okay, so we all know we had a little bit of an idea of what goes on with the blood centers. You guys were experienced the blood drive by Talent Blood Center, and you know that the blood centers and all the transfusion services are responsible for providing the adequate and safe blood supply to the patients that we serve here at the hospital. The criteria for the acceptable blood donors, so all of the criteria that is required of the blood donor to be able to donate blood is established by the U.S. Food and Drug Administration, by the FDA, through the Code of Federal Regulations. They also use guidance documents. They also use memoranda to the industry. The AABB is, again, the voluntary accrediting agency. They also establish guidelines for blood donations, and they write those guidelines in the standards for blood banks and transfusion services. The AABB came up with the Donor History Questionnaire, the DHQ, which provides uniformity and clarity for determining the eligibility criteria for donors, for people who volunteer to donate blood. So in the FDA websites and also in the AABB websites, you can see the documents that they provide in terms of requirements for blood donation. Okay. So, the screening of the donor is very important in the whole donation process, obviously. The screening occurs in 4 different phases. There's the registration phase, educational material, health history interview, and a physical examination at the end. So the physical examination is physically looking at the patient's blood and determining if they meet all the eligibility. In the whole process itself, there are 2 phrases that pertain to the blood donation process, okay? So there is donor eligibility and the suitability of the donation. The donor eligibility is the determination of the donor's qualifications to donate blood and blood components, and the suitability of the donation means a determination of whether the donation is acceptable for transfusion or for further manufacturing. So there's 2 parts to it, to the whole blood donation. There is whether the donor is eligible to donate and what to do with that blood, and if that blood is still qualified to be able to be transfused into a patient safely. Okay, so let's talk about some statistics about blood donations. That's very important. The whole blood donation, it's a volunteer force. These are people that tend to donate blood, and there's about overall blood donors, okay, as a volunteer force, have supplied more than 17.2 million units for transfusion in the United States in 2015. According to the American Red Cross, an estimated 6.8 million people in the United States donate blood every year. You guys know that there is always a high demand for blood in hospitals and emergency treatment facilities. Approximately 36,000 units of red blood cells are needed every day in the United States. Other components are also in very high demand. For example, there's a daily need of 7,000 units of platelets and a daily need of 10,000 units of plasma. So the AABB data estimates about 38% of the population is eligible to donate blood at any given point. However, only less than 10% of those people actually do so annually. So the demographic profile typically for blood donors is the a college-educated white married male between the ages of 30 and 50 years old with an above-average income. However, there are still some there is still some diversity in blood donation, where you would see people maybe more women donating and more people that belong to minority groups. Okay, so there are 4 phases in the donor screening process, and that is registration, educational materials, health history interview, and a physical examination. Okay, so let's talk about registration and identification first. So basically, this whole process includes the documentation of information that fully identifies the donor in an individual donation registration record. So questions that pertain to any name changes or nicknames are important so that we can identify the patient or the donor correctly. We also include a pre-screening for the donor eligibility status in this particular registration part of the donor screening. If there are donors that have donated before, access to past donation history is usually in the computer system for that blood center. And so the staff member would need to confirm that the donor information is correct, that enough time has passed since the last donation, that the donor does not possess a previous deferral that's based on the history questions or test results. And so all of this has to be confirmed by the staff member. Okay, all of this is 100% essential because that's where we would identify it as well, someone who is not qualified to donate blood. So the blood donation records or documentation should include the following information. You want to include the donor's full name, the donor's address, permanent address, and contact information, the date of birth. They must be at least 16 years of old. If the state obviously considers 16-year-olds to be minors, then they would need a parental consent. The gender, the date of last donation, okay, and that's because I'll talk about this a little later, but depending on when was the last donation, you may get deferred temporarily because we have to follow the guidelines. So I'll talk about that in a bit. So 8 weeks have to pass between whole blood donations. 16 weeks have to pass after a 2-unit red cell collection. 4 weeks have to pass after infrequent plasmapheresis. 2 days or more must pass after plasmapheresis, plateletpheresis, or leukapheresis. Any additional information that we may include is a unique identification number. We could include a social security or a driver's license number, a positive identification, which is a photo ID, the patient's race. Why do we need the donor's race? And this is useful when we want to select donor units for patients that require certain phenotypes that are rare. So the race could be very helpful for them. Also, what is the intended use of this donation of the blood units that we're collecting? That's one of the things that could be additional in the tag, like it's for allogenic donation, directed donation, autologous donation, or an apheresis donation. Okay. After the registration process is done, we also provide the donors with educational materials, and we get the consent from the donor. So all prospective donors have to read the educational materials, and that describes the donation process and also the donor eligibility. The donor educational materials, they typically will include in this reading material the risk factors for relevant transfusion-transmitted infections. In addition to the HIV and the AIDS virus, or HIV virus and AIDS, other information in regards to the risk of other infectious diseases transmitted by blood are present in these reading materials that these donors have to get. Also signs and symptoms, and also delineated high-risk behaviors that have been associated with disease have to be included in this particular reading material for the donors. So I'll show you a picture, and this is the picture right here. This is an example of a blood donor educational material that's provided. The donor has to have some time to go through it, through this material, and also to ask any questions if they do. So basically, thank you note, some information to determine if the person is eligible to donate, if they are, what the process is going to be, what the phlebotomist is going to do, and some questions that will be asked about sexual contact and HIV/AIDS risk behavior, and some questions that pertain to all of that. There's also some information on the do not list, do not donate to get a test. So if you, for example, if you think you may be at risk for HIV or AIDS or any other infection, do not donate simply to get a test. Okay, you could ask the staff members where a person can get a test. So basically just some general information so that the donor knows the whole purpose of this. And at the end, there's a nice thank you note from the blood center, and also the address and the phone number in case the donor has any questions. Let me just go back to this, but informed consent is also something that must be provided to the donors. So before donation, the donors must sign a written informed consent to allow blood collection and the use of the blood. So typically the blood center provides the donor with a written statement of understanding for the comprehension and a signature. So basically, what we're saying here is that the donor understands and they are able to make their own decisions in donating this blood. So the collection facility, the blood center, will have a procedure in place to provide this and to acquire a signature from the patient. So the donor does need to read and sign the statement after reviewing all the information that's been presented to them. And again, they also have to have time to ask questions. So they will get some time to ask those kinds of questions. So here again is an example of the blood donor educational materials provided by the AABB. Okay, and again, informed consent. We must get written informed consent to allow the blood to be collected and to be used. In that informed consent, there has to be an understanding that needs to be read of the procedure and the risk factors that needs to be read and signed by the donor. At this point, the donor is also informed about the infectious disease tests that are going to be ran on the blood, and notifications are sent to the donor if testing indicates that the blood presents a risk for transmitting disease. So the donor's name gets placed into a list to defer for future donations. The next step will be the completing of the health history interview. It's an assessment, okay, and it uses a document that's called a DHQ. The DHQ is basically a way to protect both the donor during the donation process and also the patient that will be receiving the blood. So it's like an extra measure to keep both the donor and the patient safe. So when this DHQ is provided to the donor, this is happening in a place where no one else can hear the answer to the questions, so that also the patient or the donor feels encouraged to say the truth and to answer all the questions correctly. There are some paper health history interviews, or there are also some computer-assisted self-interviews formats that the donor can also complete. So the method doesn't really matter. The point is the donor needs to complete these health history interview, and the interviewer documents and evaluates all of the responses so that they can determine the suitability for the donation for the donor. So the DHQ is developed by the AABB, but it is approved by the FDA as a standard. However, depending on the facility, the medical directors are physicians that are responsible for medical and technical policies in the blood bank. They have the option to add appropriate questions to their DHQs based on their center, also based on their demographics. And those questions don't have to be necessarily addressed by the FDA. So whatever the case may be, whatever their demographics are and whatever they want to ask about, they can also add those questions to the DHQ. There is a abbreviated DHQ that is the same thing, a form of this interview process, health history interview process, but it's abbreviated. So the point of doing this is really to improve the donation process for frequent donors and also to maintain the safety of the blood supply, obviously. But you would do an abbreviated DHQ for frequent donors, which include a donor history. And of course, at one point, this frequent donor has completed a full-length DHQ, especially if they've had more than one of these full-length DHQs in the last 6 months. So once you have that means that you can do an abbreviated form of the DHQ. But it is the abbreviated form is also approved by the FDA, and again, it is just given to qualified frequent donors, and we just want to kind of streamline the process, get a little faster with that. So this is the picture of the full-length donor history questionnaire and all the questions that would be. This is in page 312 in your textbook. Just some just so that you can get some ideas about what is being asked of the donors. So basically they start with, are you feeling well? Are you feeling healthy? In the past 48 hours, in the past 8 weeks, in the past 16 weeks. Also some information about the past and where the donor has lived in the past. So whether they lived in the UK, whether they lived in certain endemic areas. If it's a female, they would have to answer a pregnancy question if they're pregnant. At that particular point or not, if they've had any infectious diseases and things like that. Okay, so the DHQ, again, it could be modified depending on the decision by the medical director, but it is a document that's provided by the AABB and it is approved by the FDA. All right, so we'll talk about some donor referrals here. There are different types of donor referrals. There's temporary referrals and indefinite or permanent deferrals as well. So let's talk about some of the things that would lead to temporary deferrals or indefinite deferrals or permanent deferrals. So let's start with deferrals that are indefinite or permanent. So certain conditions will deem the patient to be deferred, so they will basically not be allowed to donate blood. So for example, some permanent deferrals can occur if the patient or the donor has confirmed a positive test for hepatitis B surface antigen, or they are a recipient of dura mater or human pituitary growth hormone. Indefinite deferrals are a patient or a donor that has had a history of babesiosis, positive hepatitis B by gnats, repeatedly reactive test to anti-hepatitis B core or anti-HTLV virus, any present or past clinical or laboratory evidence of infections with hepatitis C virus, HTLV, HIV, or trypanosoma cruzi. So these are just some examples of what would defer the donor indefinitely or permanently. There is more important, these are very important as well, but there are some deferrals that vary a little bit. So these are some deferrals for potential transfusion transmitted infections. And so it's very important that we determine these kinds of infections because it doesn't necessarily mean that they will get deferred forever or indefinitely, but perhaps it can be certain instances in where the donor gets deferred just for a certain amount of time. Like, for example, people with malaria, history of malaria would defer them for 3 years, or a person that has lived in an endemic area for 5 consecutive years would get a deferral for 3 years from the departure. So after they left the place, they were there. So it's very important that we ask the questions about potential transfusion transmitted infections, to determine if if these donors have these. Malaria, the Creutzfeldt-Jakob disease, CJD disease. There's no screening test for that, so we have to ask those questions so that we don't miss any of that. It's this screening method for potentially transfusion transmitted diseases. It's required, and travel information, immigration information from endemic areas, questions about potential exposure through travel, are really the only ways that we can find out whether there's a big potential for transfusion transmissible diseases here. So malaria, babesiosis, Chagas disease by Trypanosoma cruzi. This will deem the patient, the donor, for an indefinite deferral. Zika virus, leishmaniasis, CJD. So all of these are potential deferrals for the patients, for the donors. I keep saying patients. Okay, there are certain medications that cause deferrals based on the disease process that requires the medication, but not because of the drug's properties. It's more about the diseases that these medications are treating. So you have things like antibiotics, anticonvulsants, anticoagulants, insulin, antiarrhythmic drugs. Those may temporarily exclude the donors, but just for a certain amount of time. Medications like Proscar, Avodart, Accutane, Tegesen, these can cause birth defects if they are present at high levels and if they get transfused into pregnant women. So these are things that we need to know about. Aspirin and aspirin-containing medications, those inhibit platelet function. So donors who are the only source of platelets for certain patients. So who the donors that are doing apheresis or platelet apheresis, they get deferred for 2 full days or more than 48 hours after the last dose of aspirin. But so that really just pertains to people who are going to be donating platelets. So we have to wait 2 days for the effects of aspirin to pass. Okay, so here's a list of these common acceptable medications for donation, and also some other medications that required like a deferral. So here's some hypnotics, blood pressure, over-the-counter bronchodilators. You have oral contraceptives, replacement hormones, weight reduction drugs, myoanalgesics, vitamins, tetracyclines, and other antibiotics for acne. Those are commonly accepted for blood donation. However, there are others that will deem the donor to be deferred for a certain amount of time. So you have the Proscar, Propecia, which is for male baldness. These will defer the patient for about 1 month. Advodart, 6 months. Accutane for about 1 month. And then you can see the rest here. Insulin will deem the donor for indefinite deferral, and aspirin 2 days after the last dose, but just for platelet donation. Same thing with Plavix or Tyclid. These are anticoagulants, and then it would just, if the donor is taking these, it would defer the donor for 14 days for platelet donations. Okay. And vaccination. So some donors receive vaccinations that are prepared from toxoids or killed organisms, and those do not require deferrals if the donor is free of symptoms. Except for receiving an intranasal live attenuated flu vaccine, the use of attenuated viral and bacterial vaccines generally just needs a temporary deferral. So that's listed here. Recombinant vaccines like the human papilloma vaccine does not require a deferral at all, and a 12-month deferral is necessary if the donor was exposed to an animal in need of a rabies vaccination. So here are the temporary referrals for certain vaccines: 2 weeks for the measles, mumps, polio, typhoid, yellow fever vaccine, 4 weeks for the German measles, rubella vaccine, or the chickenpox vaccine, 6 weeks after the pregnancy. Okay, so once the patient's pregnant, they have to wait 6 weeks to get to do a blood donation, and 12 months after tattoos or permanent makeup. Skin penetration, exposure to blood, sexual contact with an individual high risk for HIV, incarceration in a correctional institution for more than 72 hours, completion of therapy for syphilis, 12 months for a transfusion of blood components, human tissue, plasma-derived clotting factor concentrates, and human diploid cell rabies vaccine. So the one vaccine that would defer the patient the longest is the rabies vaccine. Okay, and then now we move on to the physical examination in blood donation. So the first thing we do is we look at the patient, make sure that they appear well and in good health. If donors are suspected to be, alcoholics or drug users, and you can visually see that, then they are not accepted to donate blood. So we run the age. The donor's age must conform to state law or be 16 years of age or older. We look at the hemoglobin and the hematocrit, and here are your levels. So we would get those by either finger stick or by a venipuncture. For whole blood allogenic donations, males need a minimum hemoglobin level of 13 and a minimum hematocrit of 39. In females, a minimum would be 12.5 for hemoglobin and hematocrit 38%. So it's going to be very important that we adhere to these guidelines. Blood pressure within systolic within 90 and 180, and diastolic within 50 and 100. Temperature should be less than 99.5. The pulse should be between 50 to 100 beats per minute. So the body temperature could be taken in Celsius or Fahrenheit. The body temperature should not exceed 37.5 or 99.5. Because an elevated temperature obviously could indicate some sort of infection, so that could endanger the recipient. We want the blood pressure to be normal, the pulse between 50 and 100, and also the weight. The minimum weight for blood donations is 110 pounds, which is 50 kilograms. That is an FDA requirement. The blood center can ask the blood donor for their current weight. Plasmapheresis donors must be weighed. Okay, so there's two differences. You can ask the donor, but if it's going to be for plasmapheresis, you must weigh the donor. The donors that weigh a minimum of 110 pounds can tolerate a maximum withdrawal of 526 mLs of blood, and that includes all of the samples that are added for processing. A donor who weighs less than that, they can donate blood, but then we need less blood that is collected, and also the anticoagulant to be adjusted as well. So a donor who weighs, let's say, 100 pounds or 45 kilograms can donate about 473 mLs of blood. So that's the criteria for the physical examination and the whole donor screening process. So 4 phases, right? We have the registration, the medical educational materials, the donation educational materials. You have the health history interview, and also the physical examination. All right, so then let's talk about phlebotomy and how we collect. You've all seen the process, which is really nice that you got a chance to see that. The phlebotomist typically is somebody who is different than the typical phlebotomist that goes to these people are trained to do blood donation. So it's really nice that you have someone who is experienced in collecting units of blood rather than just tubes of blood. So the first step is going to be to correctly identify the patient or the donor. So remember that this is a stepwise process. So the person who first saw the donor in the registration booth is probably not going to be the same person who's going to draw their blood. So the identification process starts all over again for the phlebotomy part of this. So we need confirmation of the donor's identity. And again, it's going to happen again at the phlebotomy step. So the phlebotomist needs to confirm the donor's identity before beginning the process of venipuncture. The next thing to do is to look at the antecubital area of both arms and inspect. And the phlebotomist here will have the opportunity to select the arm that has the best vein and to check the skin. Make sure that there's no use of intravenous needles. And also just make sure that you have a good vein because you're going to be in there for a while. The next thing is the labeling of the bag, right? The primary bag that's used for collection and all of the attached satellite bags, the sample tubes, and also the donor registration form require labels. These labels have to have a unique identification number. So the labels will consist of both the numbers and letters that are readable by the phlebotomist and also barcodes that are used for the computer scanning. So identical numbers will help in the traceability of collected blood, that it specifically when components are being prepared, and also in case you need to go back to the original donor in the original DHQ. So this just gives you an extra safety mechanism for a look back investigation and product withdrawals when they are required. Okay, so the next thing we're going to do is we're going to prepare the arm. So we pretty much already saw where we're going to go, what arm we're going to use. We're going to go into the antecubital area with the large veins that are ideal for venipuncture. We then want to prepare the skin. The skin has to be disinfected at the drawing site. So where you're going to draw, you need to disinfect the skin. So the practice will vary among facilities, but we will use some common agents like iodine, isopropyl alcohol, chlorhexidine, and some combinations of those to prepare and to clean and disinfect the skin. We're going to use some swabs, scrubs, and some applicators to properly disinfect. These are all requirements by the AABB, so we must follow, okay? So the site where you're going to draw the blood, you want to scrub that with a 0.75 aqueous scrub solution of iodophor compound, and that will help remove the dirt and the bacteria. And then after that, what you want to do is prepare a solution of 10% providine iodine, and you apply that. You will begin at the part where you will insert your needle, and then you continue outward in a concentric spiral. That's the iodine that gets used after you scrub the skin. After you dry for 30 seconds, you will cover the site with a sterile gauze. Obviously, we have to ask the donors if they have any allergies, so that we use the proper antiseptics. You can use a tourniquet or a blood pressure cuff and inflate that to make the vein more prominent. Obviously, we typically use a 16 gauge needle for the collection of blood units, and this gauge needle is inserted into a primary blood bag, and then you can insert the needle in the free vein, the one that you've chosen to do your venipuncture in. So the donation time, so the whole process itself, from beginning to end, it takes about an hour, but the actual collection takes about 8 to 12 minutes. If the blood doesn't flow or it's requiring more than 15 minutes, then that means that the donor might not be suitable. And it might affect some of the components. So if you're collecting for platelets or fresh frozen plasma or cryo, that might give you an issue. Okay, so while we're collecting, we do frequent mixing of the blood to make sure that that's being mixed with the anticoagulant or the preservative in the bag. And that's really important to make sure that we, that we prevent any clots or anything from happening. So there is a balance system or an electronic scale that monitors the volume of the blood that's being drawn. So after you are done with the blood drawn, the blood draw, you will apply pressure to the venipuncture site with the gauze, and then you keep the arm elevated with the elbow straight, and then obviously the needle is disposed in an appropriate biohazard container. All right, so we want to be able to prevent bacterial contamination as much as possible. So we have to follow the AABB standards that are set for blood collection to make sure that we don't contaminate anything. Okay, so here's some adverse reactions that some donors may feel as they are donating blood, and it's common to feel some of these reactions. Most of the donors will tolerate the donation process, but some of these reactions do occur. Most of these reactions are vasovagal, which means just they start sweating, feeling a little hot, there's a little bit of rapid breathing, dizziness, nausea, maybe fainting. But in the event that any of this happens, we keep a close eye in the donors, and also we have to make the call if we have to retrieve the needle and the tourniquet immediately. So treatment should occur at the first sign of a reaction, and all of the instructions for handling donor reactions, including all the emergency procedures and medical treatment, have to be available to the staff when they train to be phlebotomists for blood centers. So again, some vasovagal symptoms like weakness, sweating, dizziness, nausea, vomiting. Some patients faint. Some patients feel twitching and muscle spasms. They start to also form hematomas. Some patients convulse. In that case, you would call for help immediately and prevent the donor from falling from the chair or hurting him or herself. And some patients have cardiac difficulties, in which case you will begin cardiopulmonary, if you were the phlebotomist, a cardiopulmonary resuscitation and call for help immediately. Okay, and some donation, post-donation instructions and care. This is really just some instructions that are given to the donors right after they are done donating blood, is that they should contact the blood center if there are any concerns regarding the safety of the blood, or if the blood is not suitable for transfusion. They should avoid smoking for 30 minutes and alcohol use until the next meal. Drink more fluids than normal in the next 4 hours. If dizziness and fainting occurs, they should lie down or sit down with the head in between their knees so that they can get the blood to rush back to the head. If certain donors work in places where they should not be operating vehicles, or if they're in high altitudes, or they are doing construction, they should just be very cautious as they return to work. Typically they can remove the bandage after a few hours, like 3 to 4 hours. In lots of fluids is one of the things that they always say. Donors should not leave the area until they are being checked by the staff and they get the thumbs up that they are ready to go. Total fluid volume replacement happens within 72 hours of donation. Iron replacement, though, takes a little bit longer. So a whole blood donor must wait about 56 days to be eligible to donate again if it's whole blood. Okay. So now just talking quickly about some autologous donations. There's different types of autologous donations with different purposes. You have the preoperative, the normal volemic, and the blood recovery donations. So why do we do some autologous donations? So sometimes the population, the general population, or certain in certain instances, a patient wants to reserve their own blood for their own use later. That is called an autologous donation. This will reduce the risk of disease transmission or transfusion reactions or alloimmunization to red cells, platelets, and white blood cells. So it's great. But there are some requirements that we have to follow that may be slightly different than allogenic donation. So there are some advantages and disadvantages. Again, prevention of transfusion-transmitted diseases, prevention of alloimmunization, supplementing the blood supply, prevention of febrile and allergic reactions, and reassurance of the patients that they're getting their own blood back, reinfused back in them. The preoperative collection is in a preoperative situation. That's when the blood collection and storage occurs before the anticipated transfusion. So this is really suitable for people who are stable, who have a scheduled procedure that is likely that they'll need a few units of blood. So they'll do that before the surgical procedure. This is especially very important for patients that have rare antibodies that make cross-matching with donor units difficult. There are also certain patients that have religious beliefs that they are not allowed to have allogenic transfusions, so that they would do an autologous transfusions. The other form of autologous transfusion is the normovolemic hemodilution transfusion. And this involves removing one or more units of blood at the beginning of a surgery. And crystalloid or colloid solutions restore the fluid volume, and the blood is stored for reinfusion during or at the end of the surgery. So that's also called an acute normovolemic hemodilution. And lastly, the blood recovery collection is when blood is being recovered and reinfused. So this is the collection and the reinfusion of shed blood. So there is a medical device that collects shed blood from an operative field, and they collect it and then directly reinfuse the blood using this device. The device will wash the blood, will filter it, and it will concentrate it. Now, just because we're doing this, it doesn't necessarily mean that it's removing bacteria. So intraoperative blood collection is not advisable if the operative field has bacterial contamination, because that would put the patient at risk. Okay, so some preoperative donation criteria. High-risk questions do not apply. There's no age restriction. If the patient weighs less than 110 pounds, the volume gets adjusted. The hemoglobin must be at 11 or greater. Hematocrit at 33 or greater, and you can donate this way up to 72 hours before surgery. So directed donations are when someone is donating directly to somebody else. There is no great evidence that the directed donations provide safer blood than allogenic donations. But most blood centers and hospitals do participate in a directed donor program, which is fine. The donor requirements and testing criteria meet the same criteria as the allogenic donation. So basically, in collecting, you would get a health history. Testing requirements are the same for directed donors as allogenic blood donations as well. So we would still have to determine the ABO and the RH phenotype, even if it's directed, obviously. And there is a 56-day interval between donations, and this may be waived if you have the medical director's approval. And apheresis is a category of blood donation or blood collection, in which whole blood is removed from a donor or a patient, and a component is separated by a mechanical instrument, by a mechanical means, and the remainder of the blood is returned back to the donor or to the patient. the apheresis procedures collect a greater quantity of a specific component than possible with a single whole blood donation. So apheresis can treat various diseases. That's called therapeutic apheresis, and we did discuss some of these in the previous in the lecture that we did before this. It was originally a manual procedure, but it involves this huge instrumentation for separating the blood components. So there's a various cell step. There's a machine that involves various cell step in the apheresis procedure. But we all know that centrifugation is the force that separates the blood into its components, and it's based on the specific gravity. Okay, so the blood will flow directly from the donor's arm into the centrifuge bowl, followed by the removal of the specific component, and then the return of the remaining blood to the donor. So all of this is within a closed system, okay? Depending on the instrument that we use, it could take about 30 minutes to 2 hours. So it just depends on the instrument that is being used. We can do different apheresis procedures like leukapheresis, plateletpheresis. Leukapheresis is the removal of white blood cells. There is plasmapheresis, which is the removal of plasma. So in this case, plasma is collected by apheresis. It can be a frequent or an infrequent donation. For an infrequent plasmapheresis program, donors they don't get to donate more than once every 4 weeks. For frequent plasmapheresis donations, donors can donate a maximum of 2 times in a 7-day period, and they must weigh at least 110 pounds. For plasmapheresis that's more than once every 4 weeks, the patient would need monitoring of their total plasma proteins, their IgGs, their IgM levels at least a 4-month interval. And red cell pheresis means we are taking 2 units of red cells that are being removed, and the rest is being put back into the patient. So donors may have 2 units of red cells removed by apheresis if they meet the specific criteria, especially with the hemoglobin and the hematocrit as well as the weight requirements. That is cleared by the FDA. That has to be required. That has to be met as per FDA requirements. So the donor is deferred for 16 weeks after donating a double red donation, okay, which means 2 units of red cells by apheresis. And in this case, saline infusions will minimize volume depletion for these patients. And here is an image of the apheresis machine. Again, using this apheresis machine, the whole blood is removed from a donor or a patient, and the component that is intended to be collected is separated by the mechanical means, and the remainder of the blood is returned back to the individual. And that ends this lecture, guys. If you have any questions, please let me know.